Minister, I think you and your treasury, you are contradicting yourselves. In a way that we are sitting in the funds, ne? And then in the funds, you'll find out that Regulation 28 seeks to say that we must invest, there's 15% that you must invest to the private equity, which is the infrastructure. But there are those provident funds that are having, RH managers. They are building hospitals, you know? They are building hospitals, the private hospitals. And the first question that I want to understand is that, what then will happen about the private hospitals when the NHI is in place? That's the first question, because we have to understand that we are investing money of workers to infrastructure, of which it's your treasury. Regulation 28 seeks to say that you as a government, you are saying that we must invest on private equity, which is infrastructure, and then there are those managers who are busy building, who took our monies and building the hospitals. I just want to understand that first question. And the second question is that, you see, I want to talk to you straight, not the panelists. I want you to answer these questions. How will the NHI be funded? Proper funded. I need that funding, not the one that was like the deputy was talking about. And also we want to know what will happen about the current medical aid schemes that they are in place. And also what will happen about the private hospitals with this NHI. That's what we want to know. And also how will the NHI affect doctors? So that is that is a question that I'm asking to you. And also, what are the challenges of NHI in South Africa? As a government, you have to outline that. And then what is going to who is going to pay for NHI, the employers or the employees? If the employees, then does it mean that the tax shall increase for employees? You see? So that's another question. Wait.
All right, Bob.
Another one is the last one. The last one is that this one is important more than anyone. The accessibility. How are you going to then be accessible for the people who are living in rural areas? Are you going to have maybe mobile clinics or what?
That's a very good question. Thank you. I told you it's a very elaborate points that were made. Do you want to give them a round of applause? I mean, they were really, they were really.
Those are similar questions. I think what we need to do, Faith, maybe I'll just take two more and then go to the minister before he forgets all the questions. No, come, let's be another round. We're going to be here for a while. Don't worry.
Thank you, Professor J.J. Taban. I see Minister Patla, I acknowledge you, Dr. Crisp, Dr. Patel, as well as the people who have sponsored you, 360 there. I just want to say to Brakandani, generics, the lifeline to NHI. But going on, Minister, I'm doing CCMDD for you. And we did the pilot for 6 months, and because it was successful, we had to stop the pilot and just go straight into the project. And I know Dr. Crisp knows what I'm talking about. Now, right there, if you want to start NHI, those doctors who are picking up your parcels are your primary healthcare providers. That's the first. If you put aside 40 billion for all the GPs, we will leave all the medical aids. Just a few cautionary aspects for the minister and Dr. Crisp. You know, the panel explained one thing, that bureaucracy is an issue, and that will decimate your relationship with your healthcare providers. So, Dr. Crisp, come back and discuss. Don't come as a principal on top of your healthcare providers. Second, and this one is so important to all of us, that NHI universal health care coverage will eventually overtake the health fiscal pace. We all know that. And in you trying to service universal health care coverage, there's one notorious thing, JJ. You know, there is a low budget that is allocated to instruments and health facilities. Now that's a caution to you that pace must be there if you start NHI. And this thing is now law. It's no longer a bill. You know, it has to be done, whether we like it or not. And I will say one thing. Your specialists, don't speak about them as if they are not special. They are very special. Ne?
So they can't be paid like GPs.
HJJ, no, they cannot. It's important to also bring them into the discussion. Very important. You know, these people, Minister and Dr. Crisp, they will handle your NHI if you treat them as they must be, including your professors. Now, your nurses, they are your springboard for your hospitals. Now, when they leave your public hospitals to the private sector side, because you are not paying them, you know, please sit with them and increase their income. We did speak to Dr. Aquina Tulare about this a few years ago and explained to her that, you know, nursing colleges that are funded by the public sector, it's basically getting families out of poverty. Thank you, JJ.
Thank you. Please give him a round of applause. Solid stuff. Specialists are special. One more.
We've got one last
I'm
one.
I'm going to come to you.
JJ.
One more and then I'll go to the minister.
Yeah, JJ, we've got one last one this side as well.
Yeah, we'll come. There's going to be another 2 rounds of questions.
He can't hear.
But the minister must answer, otherwise he will forget all you are saying. If we don't rapidly go to him, you know. The yes are not on his
speak
side.
in the next round,
You can't bombard him. Okay, Faith, you got one more there.
Yes, we do. We've got one more this side at the back. Stand up, sir.
Thank you very much and good evening, colleagues. My name is Terence Magoro from Gauteng.
Right here, Minister.
Yeah, right here. Just briefly on my side, I think the first thing that we can mention is that this entire table here, it's pro-national health insurance.
Okay.
Can we get a round of applause for that? Yeah, but...
Please introduce yourself.
Terence Magoro from Gauteng Department of Health. Now,
so it's a department table. It's pro.
Yeah.
No,
it's asking. No, it's not. It's not, JJ. It's not.
Okay, I'm sorry.
But just briefly,
Yeah.
I'm not going to take a lot of your time. But what I wish to say is that I think this is only part 1, JJ,
Yes.
of the NHI roundtable discussion. We need to have another one because the discussions earlier were just centralized around medical aid schemes. And medical aid schemes, when we're talking medical aid schemes, we're talking to the elite. We're talking about 90% of the people that are in this room. We are not talking about these people who are standing right here at the door. So it's quite, poetic and, a bit emotional at some point.
Sure.
But what is critical, JJ, is that Professor Crisp has mentioned that 8.8% of the current GDP, in health is currently being spent in the private healthcare center, 50% of it, and the other 50% is in public. And the private healthcare sector is saving about 15%, of the population. The rest is in public service. And the question is, then what happens to the amount of money that has been invested in the private health sector? Because remember, some of it will still be claimed back as rebates and government has to pay for that. Yes. So that's quite fundamental and it's something that we really cannot wish away. So, Dr. Litlape, we really, respect you a lot as our leader. You've done, quite phenomenal work, not only at the HPCSA, but he has been an engineer in setting up the National Strategic Plan of HIV and AIDS at SANAC with Dr. Simelane many years back. But we really cannot bring a lifeline to medical aid schemes that have not worked. We really cannot do that. How do you explain a situation where someone who lives in Diepsloot in Johannesburg, that person has to travel and pass Centurion and go to Tembisa, to seek tertiary healthcare services after having gone past quite a number of private health establishments that are literally at his doorstep. So we are saying at this table, the National Health Insurance is going to address all of that and ensure that there is redress. And lastly, before I sit down, Professor Crisp has forgotten to remind all of us that the NHI bill is not an implementation plan. So it means the details about what is it that will be done when the board is appointed, how registration will be done in relation to private healthcare providers, registration of users as well. All that will be outlined well in the plan that Professor Crisp will share with everyone. Many thanks.
All right.
Thank you very much.
And that's where the devil is. The devil is in that detail. Minister, you've heard what the stakeholders have had to say. Let's start with the funding issue, because it came across on at least 3 of the questions. Start with that, and then, of course, you make some notes there in terms of what the other questions are. But I think the funding issue, even from the panel, they were tackling this funding issue. While you are at it, just assure South Africa about the governance of that fund, because people are saying, my God, they're going to centralize the money, we're going to be in big trouble, and so on. So if you can start with that, just to start us off.
Well, thank you very much. Thanks to the moderators. My apology that I couldn't be here when the whole discussion started. I think I did send the message that I was stuck somewhere near the Beit Bridge where the flight couldn't take off, because there was a door which did not close for the flight, so they had to order another flight to pick us up. But at least we are here now. In terms of the funding, I think just as I came in, as the panel was discussing, just to reiterate, to say in terms of the source of funding, I think the comrade from NUMSA also did raise it. Yeah. What we are saying is that the problem of access to quality healthcare services in South Africa is multifold. But one of the key ones is not the fact that the country is not spending enough on health services. Right from the primary health, health promotion, right up to the most advanced tertiary services. Comparatively, compared with many countries, South Africa spends much higher. The only problem is that in terms of that spending, when we put together what the fiscus spends and what we spend in terms of the voluntary contribution, when you put that together, what we're talking about here, what BHF members and also their counterparts in the Health Funders Association, those funds which they manage for the members, when you put all that together, we are much higher than many, even high-income countries, much higher, in terms of GDP spending. What is the problem is the fact that we must find a formula through which we can be able to pull together those funds. Now, the most reliable, of course, is the fiscus, the 250 billion or so total, which is allocated through the fiscus. But that's just the direct funding to departments of health. But there's also funding within government itself, at municipal level, in various state-owned enterprises, also in other departments like correctional services, they run their own health services. If you pull all that money, and then even just a fraction of what me and you who have income spend on what my colleagues are managing, the administrators and the funders, a fraction of that, if it can be properly, pulled together and rationalized, and agreeing with other colleagues who have said about, for instance, what the issues which the health market inquiry have raised in terms of poor regulation, and make sure that the investment, comrade from NUMSA, those monies of yours, and I'm happy you've mentioned, and also I think supporting what Dr. Leklape was saying, that the notion that medical scheme money is private money is a misnomer, because as you yourself are saying, the private, not only in terms of the funding side, even the provider side, many of these big private hospitals are also using provident funds funding, which is workers' money. So what we were saying is, on the funding side, take what the fiscus already provides, add to that a contribution, comrade, yes. The advocacy here is that those of us who earn income, as it's happening in various aspects of life, whether it's about your pension, those who are not employed depend on SASSA to get their pension. Those of us who earn income, Dr. Leklape says he's on SASSA as well because he's unemployed. But all of us who earn some income are expected to either have a provident fund or a pension fund. Equally so, that's the solidarity that's how organized societies function. So we're saying also in the area of health that over and above the normal fiscus which is allocated, it's important that we shouldn't leave this aspect of an additional contribution as you do with your provident or pension fund, over and above the fact that if you don't have it, the state will give you something. Contribute and make sure that with all this infrastructure which is available, and the professionals, the specialists and the nurses and all that, they should then be able to be funded such that they can be available. And we're convinced that with a proper management and also a proper regulation, both of the funding side and also on the provider side, we can actually spend much less and still be able. And we not have to reinvent the wheel. I mean, all of us here know.
Is there an assumption, though, that the specialists must get used to the fact that they won't be able to charge what they are charging now in a less regulated environment? Because that's where the whole thing about skills flight comes in.
All the providers. Yeah. All the providers. I mean, most of us here in one way or another are involved with the South African situation, ladies and gentlemen, is not sustainable. What we are in now is not sustainable. In terms of the weaknesses which are there, which we accept, in terms of the managerial capacity and infrastructure on the public side, there's a lot which we are trying to improve and make sure that there's improvement. But I want to argue also, even there, JJ and the ladies and gentlemen here, that notwithstanding the weaknesses which are there, we're not talking about the situation of, where you can compare with, some of our, even countries at our level of economy, where the public health system is neglected. There's weaknesses in our system, but it's not neglected. If it was neglected, we would not have even managed to manage the pandemic like COVID. Even at the time when, through our own policies, we must accept, when we're denying people ARVs, and thousands of people were sick and not being properly cared for because they were not getting ARVs. The system, we had a lot of deaths, but the health system did not collapse. The pandemic came, there was pressure, but it didn't collapse. So I want to appeal to those who
I'm saying that the stories we are hearing about hospitals that are dilapidated, no linen, no food, Paraguay running out of food, all those are anecdotal when you look at the totality of. Is that what you're saying?
It's not anecdotal.
Because a lot of people are saying the health system is collapsing.
It's not anecdotal.
Yeah.
If you can go to Chris Hanibara, the might have had no bread,
On
true,
that day,
which is
yeah.
not, should not have happened. If you go there now,
Yeah.
if you go to Bara now, you will find a hive of activity, some of it which should not happen. Because the reason, for instance, now if you go into the casualty, because people are drunk, they are fighting, shooting, car accidents, the people who are in that casualty, they know they are not going to sleep. But if you just go, that's where the inequity shows its ugly eyes.
Yeah.
If you just drive a slightly shorter distance and just pass Bara, and I don't want to mention other people's places, but go to the other places, you will find people quiet, nice and waiting.
In casualty.
In fact, very interesting, as we were waiting for the flight which couldn't close the door, because we had to wait for 2 hours for another flight, and the mixture of us and some of the people we were with, because, maybe I shouldn't mention the company, well, De Beers was the one, and then maybe because it was a public fund, we were also with Afrocentric, and, so we're chatting. And as we're chatting about the pressure on the public health system, and a lot of us who have worked in casualties, saying when you are there you don't sleep, and there's some gentlemen who are more in the private sector are saying, we go out to look for patients. Because, and he was telling us the incentives. He was saying, when the ambulances and the other people actually provide us, there's some goodies which we give because you have brought the business. Because sometimes you have less than 50% occupants, and that's bad for business. So now that is the kind of thing which in trying to address. I'm not denying the fact that there's in the framework, because the NHI bill is just a framework. Yeah. I'm not denying the fact that there are areas which many people have pointed out, which we should attend to. And I'm sure, as Dr. Crisp and others have said, it's just, this is meant to be incremental, start from the primary and go up. Yeah. So, and the governance, which I heard you also, we do acknowledge the fact that there's, I think Faith did say, a big thing is the trust.
Trust deficit.
The trust deficit. Well, it's historic, it's also current. We accept the fact that...
How can you convince us, how can you give us a sense of comfort, right, that fund that's now going to be centralized, right, is going to be well managed, if there's already a big question mark over how the people who are going to be there are going to be appointed, the governance of it, etc., because the track record doesn't smell too good.
Well, if we talk about a track record of some institutions, it's a mixed bag as well. Yeah. Because as me and you have discussed before, the mixed bag in the sense that in the state itself, there are also institutions which actually have been managed well. I think Dr. Crisp gave the example of, your government employees pension fund, which sits over trillions of public services workers who, when they do retire, they do get their funds. They get paid and so on. There are a number of other weaknesses. But what I want to say also there is that the issue is in terms of a single fund. What we may still have to look at, because this, as they say, the operations is one of the details. Yeah. Some of the things which are not necessarily sort of cast in stone, which we may have to, in looking at
Please,
the
let's listen.
We may have to look at in operationalization, is the model of administration. Because what you have in the bill is more high-level governance. Yeah. But in terms of the actual fund administration, I believe that those are the things which, from the...
Yeah, please, if there's some doctor, there's lots of doctors, please attend. All right. Okay, we'll pause. I hope it's nothing you said, Minister.
No, it can't be what I said. could have happened.
Let's begin. What are the other questions?
Yeah, we must move quick. Eh? Okay.
Because I want to take 2 more rounds for the evening.
Just take one more. I've had a long day. I've had a long day. And I'm going back to Pulkwani at 7 tomorrow.
I'll do 1 more round. You respond, and then I'll give the panel to close the remarks. And at the end, if you want to just say something to close, you have 2 minutes.
I'll try and summarize. I'll try and summarize.
Summarize the other questions.
Yeah, because they are interrelated. Yeah.
So, Lebu. I can't see. Sorry, Minister, this is Lebu Kande. He's the chairman of our company.
Oh, he received me outside. Yeah. He's the one who received
Oh,
me.
he's receiving. Do his job. No, I was saying I can't see. So tell me what's happening so that we know whether to resume.
They can't take her out. She's on the floor. She's right on the floor. The hotel doesn't have emergency. No, I was worried, but you know, when they tried to close this door, and then
Okay, I'm told that we can resume. Thank you for the doctors who sprang to action. It's part of the NHI. Okay. Dr. Lenyai over there complained that specialists are special.
okay.
Right? And this theme comes up a lot, and I'd like you to answer a couple of the questions. It comes up a lot as if, and I think he raised the thing that you and I must agree on, that involve the specialists so that they also feel part of shaping this thing and not feel that they are being seen as a pariah there who've been overcharging and they must just stand on the sidelines. But do just address a few of the questions and I can take another round.
Let me try and be brief in terms of just touching on, maybe just the key issue as, on the fund, I mean, in terms of the fund, its security and management. I was just saying that the principle here is that the reason why you need one national fund is to make sure that you have the kind of muscle and volume and be able to have, you know, the distribution of the resources and access. What people are worried about, and which one would say it's something which we can discuss, and even there are a lot of people here with a lot of experience of managing health funds. The administrative issues. There are a lot of things which we can, within BHF, you have both the funds and the administrators in all the others. So there are issues which we can sit down. The thing which we believe that is untenable is to have multiple funds. How you administer the funds, the system, the options of various ways of administering and making sure that there's administrative efficiency it will be foolhardy for the state to ignore all the experience which is there within a number of those. They've been managing, even if it's for their specific members and so on, systems which have been developed and so on. As we move on in terms
If there
of...
are guidelines, why is it not difficult to have multiple funds? Because if you have multiple funds, if something goes wrong in one fund, it doesn't affect the whole country. Now you have to centralize this thing. The next thing, like the SASA grants, they say, no, it's delayed, there's a system glitch, then everything is in collapse. Don't you think that's a risk?
No. That's why I'm saying we must differentiate the fund. There is nothing which says a SASA fund, a pension fund, I mean the old age pension fund can be, you can have the post office and have any other administrative post bank and others, so that the system basically is the same, the fund is the same, but the administration, you may have to bring in different components in terms of expertise and so on. So, but what is untenable is the issue, the problem with multiple fund. Multiple fund is what we are having now. Multiple small funds, which must all go and negotiate and develop their package. Now, if you say, okay, why not have multiple funds but only regulate? But it's, there will still be a shortcoming in terms of making sure that you've got the volume and the size and the authority to be able to determine the full package at any given time and make sure that the standards are kept and all that. So I would appeal, therefore, that if we look at it from the fact that I know that because we're getting into uncharted waters. I think the problem with where we are in South Africa is that over the 29 years of democracy, and I blame my own organization which has been in government, that instead of making sure that this equity is driven much earlier, we then allowed a proliferation of these multiple organs. And now when we see that it's not working, we want to now, maybe it might be that, and people say, but why do you want to do it so quickly? Yeah. Why don't you do hambakashle, just come slowly? But if you hambakashle too much, nothing is going to change as well. So I would say that, I mean, where we can look at the expertise which is there, and also making sure that the things which many colleagues here are worried about, capacity to manage, avoid issues of corruption, but also just to say that, remember that the way in which this is envisaged to function is that there will be very minimal kind of issues of actual procurement of, because I think sometimes our mindset of procurement of services currently is a fee for service. That's what we know, that you fix my broken femur, this is the price, this is the theater price, this is this and that. But the fact that actually the very same professors and specialists, very important people, the specialists, we can actually agree that this group of specialists are looking after central Johannesburg and all the orthopedic cases, and they are in a group practice. And this is how much, this is the population they're looking after, and this is in terms of the areas, the specialties in which they are the best. This is how they will be reimbursed. You then, because you're not going to pay on invoice, like what the schemes now have to do. Every doctor must submit an invoice. And then that's where the corruption also it becomes a problem. And also within our own public system, because of this. So that's where I believe that, but I want to emphasize again that I heard the gentleman from BHF saying that we are not engaging. We'll find time, we'll spend time again. We'll spend time with you because...
So you're engaging, but it's superficial.
No.
I know Dr. Chris will disagree with that because he's been...
Well...
He's pulling his hair.
I want to make an undertaking. I already have I know that some of them are also members of Business Unit South Africa. And I've already assured Business Unit that we are going to engage. And I don't want a Zoom. I want a physical meeting. So that if we need to lock the door, we must lock the door and throw away the key and find each other. So we're going to go. But let me just say on the flight of skills, it's a matter which also, when you are in Parliament, there's one opposition which always say, no, but people are going to leave. But, you know, if you care to know, so many of the countries which some of the people, want to go to are already moving in the direction of universal health coverage and doing away with fee-for-service. Many countries. In fact, just next week after next, we have the United Nations, what is called the United Nations Assembly, amongst which there are various issues which are discussed. In the coming week, I'll be going there with the President because the Secretary General is convening the UN. Amongst the topics which they want feedback as to where countries are is implementation of universal health coverage. So all heads of states will be sort of sharing.
Basically saying there's no way to run.
Essentially, even your most capitalist countries. If you go to Canada, I don't know if colleagues here have looked at what our colleagues who go to Canada, where do they end up? They end up in the rural hospitals. They end up in the rural, they are not running private practices there in Canada. They are not. They are in the most rural hospitals. Some years back when I was there on a parliamentary visit and we were having dinner with some parliament, and the gentleman thought he was being very complimentary to me. He said, you know, hey, if it wasn't for South African doctors, we would have no doctors in my hospital. You know, we are very lucky. He was still alive because of South African doctors. And it was not in Toronto. It was in some small town in the outskirts. And that morning when we arrived, when we went to visit a health facility, it was a clinic. It was managed by a young UCT graduate. He was probably in his late 20s or early 30s. But he was running a rural clinic, public, in Canada. So I just want to say that.
No, which is a good thing because you need to get more doctors to want to work in rural areas.
But they would rather go to
rural in Canada.
That rural, I just forget the name of that.
But the issue is,
and rather than go to Malamulela.
Yeah. But I think that the issue is that, are you satisfied that you have engaged?
We are engaging.
Health
we are ready to engage even more. But there are things which we can't lie. Colleagues, we can't lie. We can't claim that what we're having now is sustainable. Where, I accept the fact that I think some of the panelists were saying we must just improve on regulation. There's an extent to which, yes, we must strengthen regulation. This situation where, even in the private sector, you know that if you are operated at, let's say, the clinic, by a particular specialist who operate there, and if you are operated at some other place in Sandton, the bills are going to be 10 times different. You know, that's exactly what. So we agree on the fact that. So what we can't lie to our colleagues is that the direction we are moving will not be lead to a situation where, instead of grossing 10 million or more per annum, over and above the 2.5 million or 3 million which you are paid by the state. Because what we're having now, I accept that some of those is the weaknesses of our own administration. Many of those very important people, specialists in some of these areas, some of them we pay full salaries, but they spend only a quarter of a day in the public sector, and they are also supposed to be teaching, and there's a very clear. I'm sure many of us who in the profession, if we are honest with ourselves, our younger graduates who are coming up now. Dr. Tlapa was in the HPC. I'm sure you'll attest to that. The standard of competence which is arising over the last few years, because of the fact that many of these very well-qualified specialists of ours also. So what we can't lie is the fact that the direction we are going will be a disadvantage in terms of if somebody could afford Maserati today, probably down the road when the NHI is really effective, they will not be hungry, but probably they can still buy a Mercedes-Benz rather than a Maserati. But that's the direction so I'm quite confident. Even about a few months ago, I spoke at they don't call it. I'm not a specialist, though Dr. Crisp can correct my language again. They call it the admission to the College of Medicine.
Yeah.
There were quite hundreds of postgraduates, about 600, getting their fellowships and they invited me to speak about the NHI.
Yeah.
And many of them were saying, look, we want to serve this NHI. We are South Africans, give us an opportunity, we will be there to serve. So there will be some who will leave, but there are many who will stay. I think the future of schemes, I think, in a way I've indirectly answered to say that our direction is in terms of the fund, it must be one national fund. How it is managed and administered, we may look at different models.
But the medical schemes will be obsolete. Let's be honest.
Well, that's down the line, because what we are looking at is built from the bottom.
Yeah.
Also acknowledging the trust deficit and the capacity. So we are saying start at primary health.
Yeah.
That's why we say the NHI should be implemented in phases.
Yeah.
And even in the bill, it says...
But the medical aid must prepare to scale down. Let's be frank about it.
Well, down the line, they have to scale down as the national fund gets more competent and has more capacity. Then otherwise it becomes a duplicate.
Yeah. One of the panelists suggested that instead of doing that, which will get them out of business, you should change your regulations so that they can accommodate more people. I mean, is that even a thought?
The low-cost medical products, that's a disaster.
Okay.
That's a disaster.
Oh, you heard her.
No, I know what they're talking about.
Yeah.
That's a disaster. In terms of saying that the solution is low cost, let me just ask with your indulgence.
Yes.
She must explain to us her understanding of what package of service a low-cost medical scheme will cover.
Pumelele, just take it.
Just that. What is your understanding of what a low-cost medical scheme will cover?
Hi, Minister.
Please stand for the cameras. Yes.
It will certainly be more than what a gap cover provides. So it will cover for those. So currently, the 15% of the population that's covered by the private sector earn about 30,000 rands. So that's the current household of current purchasers of medical schemes right now as we speak. So we want to include more people, because right now people cannot afford the traditional medical scheme in its current form. So when we introduce low-cost benefit options, someone earning 5,000 rands per month will be able to afford cover, which is not simply
but
gap
what will they be
cover.
covered for?
It will,
Just give us an example.
It will cover prescribed
Hospitalization?
minimum benefits. It will, it will, some. It will cover the critical
All right, please
prescribed
give her a chance.
minimum benefit
Yeah.
options. And
But do you agree with the minister
and-
that that's a poor cover? In other words, if you are to go into sophisticated surgery and those kind of things, prolonged
Well, it
stay
depends.
at ICU, you'll be out.
Look,
If you-
it's
they will
it's
come and
going
tell
to
you,
be
you must pay half of
aligned
it.
to PMBs. And I see,
No.
it's a better quality
JJ,
than a gap
Than
cover.
nothing.
Let's not waste
Let's-
people's time for the night.
All right.
Let's not waste people's night. You
No,
know,
Minister. Minister.
sorry.
All right, Pumele, it's okay.
Pumela, sorry.
Yeah.
The bottom line, JJ,
Yeah.
this is a disaster. you're asking us to authorize a disaster. Somebody walking around and saying, I've got a medical aid. But if they collapse there and call 911 and they say, okay, what is your cover? Oh, okay, go next door. That's where it's going to, I mean, already, nah? I'll give you an example.
Yeah.
Already,
I'll give you a chance.
whether you go to currently jams,
Yeah.
various levels of jams and various other schemes. I'll give you an example. I mean, in Parliament, we have no option. Once you are a member, you're sworn in, you're obliged to be a member of a scheme called PAMET. I mean, with myself, with one dependent. I mean, all in all, I pay something like upwards of 15,000 a month. With one dependent.
one dependent?
Yes, with one dependent. But I can tell you, it's almost unavoidable that with my blood pressure tablets,
Yeah.
if I go to the pharmacy next month,
Yeah.
they will tell me your funds are exhausted. Yes, it happens every year. By October. Now,
So you must pay now for this.
no, I have to pay.
Yeah.
I have to pay. Now, all that I'm saying is that this option of you don't want people to be fooled, to be carrying a card which says, I've got a medical scheme cover. But when the rubber hits the whatever, there is nothing. You know, you can have one GP consultation or two, or I don't know how many GPs, I think 3.
Yeah.
There are 2 or 3 GP consultations. You this and that, that's it. That's it. So, I mean, I know that there's a lot of clamor for that. All that it will do, JJ,
Yeah.
at the end of the day, a big percentage of that is going to go to administration. It's going to go to administration.
And not to the health.
Not to go to, the person will visit the GP twice or thrice. That's it.
All right. Okay.
So-
let's.
so-
I want to take another round.
So
Minister.
that's not the solution.
Yeah. Pumele, you'll have a chance to do a closing remark. I'm going to come to the panel at the end to give closing remarks and some of your responses to what the minister had to say. Let's see the tables that have not had the chance to follow up.
Remember, we've got a follow-up here while the minister was speaking. So while
Okay.
you're finding somebody
Quick-
that side, can I
quick
give a quick
follow-up?
follow-up?
All right.
And hold the microphone because there has to be a very quick follow-up.
Anyone here? Or over there?
No, I need.
Not a long time. Just a quick,
All right.
a quick follow-up. This one.
Okay.
Okay, Faith.
All right. I want to talk to the subject of low cost benefit option. And the first thing that I would like to note is this is not a new product which people are asking to come into the market. There's a misconception that the current insurance products which are being exempted by the CMS are low cost benefit options. They are not, and we agree, they are inferior products, they are expensive, they are inefficient. You have said things quite correctly, Minister. What we are asking for is having low-cost benefit options offered by medical schemes in a much more controlled and regulated environment that will allow the beneficiaries to have benefits which can be monitored, and we trust and believe that they will improve with time, because in a medical scheme context, cost of health services, what is known as the claims ratio, it will be around 90% or less. The CMS reports indicate that these low-cost benefit option products that are in existence, being incorrectly called low-cost benefit option products, have claims ratio of 40%. So yes, they are stealing from the poor people. Allowing low-cost benefit options in medical schemes will also allow the participants of those products to get access to medical tax credits, which we currently enjoy while you still earn more income. But the insurance products are denying access to the same medical tax credits to the people who do not afford. So let's have the honest discussion around low-cost benefit option. Why is it not being allowed in schemes, yet it's being allowed in insurance companies, which end up harming people, like you are saying? They think they have comprehensive cover. When they go to hospital, they discover they don't have enough.
All right.
And then, one last point. There's a misconception that benefits run out. Only certain benefits.
if you are hypertensive, you will have full cover for the whole year. If your scheme is not paying, go and tell them this is a PMB. They will pay for your meds for the whole year. So let's get.
Take the microphone. Gotta take the microphone. Otherwise,
Okay.
it's a whole day.
Okay,
But much appreciated.
Sounds
much
like it
appreciated.
requires its own
Okay, I
seminar.
need to go to a table that also has not had a chance to speak. So let's go to the sun and then we'll come back again. I'll come back.
Thank you very much. understand how the average ordinary person is going to be heard. How can they lodge their complaints? How can they choose what they prefer, actually? So that was that. Thirdly, the issue of communication, which again came to the fore. We'd like communication to be strengthened. It's one thing to speak on a technocratic level. It's another to bring it down to the people, to understand in languages and in simple terms that they understand. It needs to be ongoing, effective dialogue. So that's what we're also proposing. And then lastly, the pilot study of 2012 to 2017, it focused on quality, and there were some recommendations that came out. We'd actually like to know what happened. There were billions used, there were 12 pilot study, 12 districts chosen. We'd like to understand, because that could also give us some.
There could be results of of those pilots that tell us whether the NHI is working in that context.
And we don't have to restart the process. So that's our 2 cents.
All right, great. Great, fantastic.
We're
Faith?
trying to get voices that have not spoken as yet. So let me go to this gentleman, Mr. Andile. Go ahead, sir.
Thank you very much. Doc, JJ, I'm not going to sponsor any solution because we waited. I think it's 3 things, Doc. One, we, in this table, half of the mandate, we do support the NHI bill. But the second one, Doc, on your example, Minister, about Bara, we are from a trade union. My colleague, firstly, Comrade Ugusha, spoke very well. But we are worried there are families that we are supporting, our immediate relatives, our neighbors, and in your own organization, you'll understand when I say your language, our people, what it means. The public hospitals today, the plan towards NHI, we understand it, but public hospitals today, our relatives are suffering. Today, last week, one person I know had to wait for 6 hours for a bed in a public hospital in Utenek, not at Bara. And the conditions in some of those hospitals, the smell itself as you enter makes you to go back home because you don't feel that you'll be safe there. One of them had to be discharged because doctors were saying, or nurses, because there are no doctors there, nurses were saying he is safe at home than in a Utenek Provincial Hospital. Siyacela, Minister, as you construct this good route towards NHI, can you please make sure that attendance to the infrastructure in public hospitals is prioritized? I do have a medical aid for now. I don't know tomorrow. But the conditions in those hospitals needs to be attended to. Thank you very much.
Thank you. Thank you, Dave. Just introduce yourself. I'll hold the mic.
Okay, thanks, JJ. My name is Simon Madini from the South African Medical Association Trade Union. Firstly, Samatu is the trade union that represents doctors in the country. It's registered and recognized. So I'm in a good standing. I've got a constituency. Yes. Now I've listened to the panel that was here. They were all speaking to similar issues. First, governance. Secondly, funding. As if those are the only 2 components in the value chain of the healthcare system. And that is very wrong. I'm not going to speak about stats of how much is paid to who in the private sector and the public sector. But what I need us to look into is what we are not talking about here. That the bulk of the marginalized end up going to public hospitals that are underfunded. And as a result of that, there is one component that people will say, but there is a budget for the public service. They don't tell you that part of that budget is for contingent liability. When the same patients and communities that we're servicing sue the states for medical negligence, which 99% of the time is not because of the unskilled doctors, but it's because of the infrastructure that needs funding. So the current system, whether they like it or not, it's not responding positively in the public service.
Are you saying that there's a problem with the infrastructure? Because the minister is saying the health sector hasn't collapsed.
No. We are not saying it has collapsed, but it is a value chain. There is a recent story in Northwest where babies were fitted in card box. There were no incubators. Now that is part of the infrastructure. Now there is one other component that is very critical that we need to look at. People that render service, your healthcare professionals. If they've got to cater for 86% of the country, now are we then saying that at the end of the day they would be normal? We've got doctors who are suffering badly from mental health, not because of their own doing, but because of the system. So the current system is not working. Do I favor NHI? Yes, definitely, because it is the alternative to the current. Do I favor the Department of Health? No, I don't. But if it's the department that brings the alternative, I will support the department. So the most unfortunate part, and if I seem to be rough, my apologies. You see, our biggest challenge today is the rising number of black academics who lacks political content, who only when they talk about the problems of this nature, their focus is on money. Not even a single person here today said, but people are dying in hospitals. Not even a single person. It's all about what are we going to get, who's going to be given what, who's going to manage what. But the question is, I mean, if you look around, it's very black here. And you don't hear them saying, but our mothers and brothers and sisters are dying because of the current health system. They're very quiet. When they leave here, they'll be driving their Mercedes Benz. Get in an accident, what's going to happen? Insurance comes, Discover comes and pay. But do the very same communities that were servicing have access to that? They don't. If a person gets in a car accident with a taxi, what happens? We all know, JJ. They've got to wait along the roadside for an ambulance that would take 3 hours to come and take them to the hospital that is already overburdened. Now, what we're saying as Samatu, redirect the resources to where they are needed the most. And that most is the majority of this country. One last part. There is this notion that doctors will leave. I don't want to use Juju's words, but I'll tell you one thing. Any person that is patriotic to this country will remain behind and fix it. Those who leave do not care.
All right, thank you so much. All right, I'm going to ask the panel to give me your parting shots also for the minister's consideration in the next session we're going to have. So let's give me your parting shot. Let's start with you.
My parting shot is, I like your shoes. but having said that, I think the fundamental problem is people went into the struggle to fight separateness. The separateness of before was black and white.
Okay.
In health, that separateness remains. It's no longer black and white, but it is stuck. And it was created by privatizing public health, systematically and progressively. And those of us that belong in that privatized, privileged health have forgotten where we come from. That's why it's easy to other our own people. Where you sit, you have medical aid, you have access, but you complain to Letlape that help me. My uncle, my mother, my sister is on a queue in bar. And you never look at yourself to say, but how can you sleep at night when you are now the own oppressor of your own relatives? It's the separateness that is a problem. And, 3 things. 1, those that lead must get their health care to where they are taking us. Scrap. That's why I insist available resources means the national medical aid and the budget. Have the courage to bring them together. Let us not apologize to white privilege and privileged blacks that have joined white privilege. let us deal with it decisively. 2, I spoke in Kigali yesterday that it's about time that those that work in the public sector are paid properly, so that the care they give is the care they will go to for, that they will take their families to. In 2010, we lost a young man in Witbank who was stabbed by a mentally ill patient in a hospital. That was a regional hospital, part of the teaching circuit. When he was stabbed, he was being rushed to the private sector. And he died in transition. And that's the new South Africa. So let's stop fooling ourselves. Okay? This is a good attempt. I support it, but it does not go far enough. It needs to pool national medical aid funds with the budget into one. We need to talk about, when we say universal healthcare, Minister, I plead with you, as you do pulling of the resources in the public sector to reform it, pull the resources in the privatized sector in accordance with the recommendations of the HMI to reform it. Because with a statutory fund without statutory tariffs is a disaster. Let us not wait for later. Let the expertise that has been created by apartheid health, that sit in BHF, in CMS, be part of the secretariat that we have. Gems is a bad word, and when you get gems, you die. But it could have been a terrible thing. So I'm responding to it. So, Minister, it's time for bold, decisive action. Not pussyfooting when we use the name national. If it's national, it has to be for all of us. It has to be for all of us. Cyril and the minister must be the first to go in. Me and Nicholas will follow, and Adrian Gore will be right behind us.
All right, thank you so much. Dr. Rajesh, your parting shot.
My parting shot is to commend 360 for organizing these events. We've been saying for a long time there's need for engagement, and I'd like to thank you for this. This is a great start. Minister, to you, there was comment made about patriotic people. There's a lot of patriotic people even in this room. And I think between us in private sector and in public sector, there's a lot of goodwill to solve the problems of the country. Let's talk to each other some more. Let's put some more suggestions on the table, and let's take concrete action. We can't wait 20 years for no reform in the medical scheme industry or even the provider industry. There's many dysfunctional regulatory bodies out there. Let's start fixing them one after the other. Thanks.
Thank you, Dr. Rajesh. Please give him a round of applause. Mr. Osborne.
Okay, thanks, JJ, and thanks, Minister. My only part I want to say, I just got surprised sometimes. Minister says maybe he's antihypertensive, run halfway through the year. I ask myself, but who does the regulations? Who does it control? He's in control of the rules. Why don't you change the rules through your bodies of the ones that you regulate? Why you come and complain like a victim like us? I don't understand. The second part, people talk about NHI. There is a fund similar to NHI. It's earmarked we pay through our taxes, through the fuel levy. It's called the Road Accident Fund. If you know it is technically insolvent since it was established, it cannot meet its liabilities. People talking about here that someone got an accident on the side of the road cannot be taken to a private entity. Do you know that Road Accident Fund is supposed to cover that? Why it's not doing is the failure of this national fund that you're looking at. When you are having fund that there's no competition, why can't you deliver the services? When they say medical schemes are going to deliver complementary service, why are they scared of competition? Why you've got public schools, but there are private schools. Why they don't want the same things happening? Why they don't want it? Because people are marching with their fees. They will move from Soweto and send their children to Kuro in some places that is Donji and sacrifice their sentences because people have got options. Now they want to close the options. And you've mentioned the things of going to, now they will seek healthcare outside South Africa, like any other African countries. So, and to me, I get to be surprised when they say medical aid money is not a private money. You're almost like saying Stokvel money belongs to government. Those people, when they credit a Stokvel through medical aid, it's a non-profit organization, it's their private money. If they dissolve it, it goes back to them, it doesn't go to government, besides if they change their role now. So this is very important to me. It does not create something they can create multiple funds, and again, they can regulate and improve what's happening. But you can't be a victim of circumstances while you've got a hammer to solve up the problems.
Thank you so much.
Thank you, JJ. I'd just like to start by answering the question from Dr. Moloko. I did not say 95%, it's 91%. So the 225 billion is actually 91% of the contributions from the members. And that money was paid towards their treatment in 2021. I got those statistics from our actuary, so they're quite factual. And then to you, Minister, you were not here when I was given a chance to speak at the podium. We as the Health Funders Association are ready and willing to work with government. We're willing to work with yourselves. We don't believe that NHI in its totality is a bill that is misinformed. We do know that if we improve certain segments, it will bring us to a point where we are able to provide universal health coverage for all, which speaks to quality, accessible, and equality for all South Africans. That's what we believe in. And I just want to emphasize this point. Medical schemes, if you are covered by a medical scheme, you will not pay out of pocket for prescribed minimum benefits, PMBs. You're not allowed to. So, and those are more than 271. There's more than 271 listed prescribed minimum benefits. And so those are linked to chronic and hospital treatments. So I need to reiterate that because I think we're talking past each other. Government and the private sector is talking past each other when it comes to this. People who pay out of pocket, it's when you're seeing a podiatrist, you know, but if you are in a critical situation, all medical schemes will pay, and you will not be required to co-pay. So I just need to set that record straight. Thank you.
Thank you very much. Dr. Crisp, you got the last word.
Okay, try and keep it short. Thank you. And Nani, thanks very much to you and your company for sponsoring. JJ, Faith, very pleasure being here, working with you again. And to everybody who came and listened and participated, I'm sure it won't be the last time. What I want to say is we have enough money to run the health system in this country for everybody. Everybody, all 60 million people. We have a lot of expertise, a lot of experience, a lot of resources, and we waste them. And we forget that the whole reason for a health service is for the 60 million people who are the users of the system. We need to shift our emphasis to preventive, interventive healthcare rather than focusing everything on curative healthcare. We need to restructure the way we do things. We need to, restructure the way that we use these resources. And we think that after more than 20 years of working on this green paper, white paper bill process, this is the right approach. We think that you should join the ride into the future with us and argue about the details along the way. But we think that not changing things as they are now would be the only real disaster. Thank you.
Thank you. Please give the panel a round of applause. And we're going to now do a wrap up with the minister. Okay.
No, thank you.
Yes,
I
Minister,
hope
your comments.
I'm audible. No, thank you very much. Let me also thank you, JJ, and your team for organizing this.
Yes.
I know I missed a bit earlier on, but it was worthwhile, even as late as I arrived, to be part of this. I want to assure the participants that we take your comments, your inputs very seriously. And when we say that, we will continue to engage, because indeed, we don't think that this is an event. This is a process. The passing of the bill, it was a necessary event to create a legal framework, and that process is carrying on. There will be some space in this process to the extent to which there could be some changes. One is not in charge of the legislative process. Those who are in the legislative process in the Council of Provinces will be able to guide. But I want to say to all of you to say that even beyond the legislative process, the implementation is indeed going to be a journey. There will be a number of steps, and as all those steps are being taken, there will be opportunity for various role players to be able to make inputs. But I believe that it is necessary that some significant reform, as Dr. Letlape was saying, bold initiative needs to be taken. Otherwise, this where we are now is just not sustainable. And I want to assure the colleagues that indeed in this process, we understand very clearly that the public health system will continue to be the building block of any transformation. And therefore, the investment in the improvement of the facilities, the equipment, and the staffing is very critical, because even though the public health sector consumes significant resources, in terms of the extent to which it can contribute towards alleviating the health needs, it's fairly, it will improve once you integrate the systems, but the public health system will remain the bulwark of carrying the health of the people. So I want to just close by saying, therefore, we are committed, we're doing everything possible. There is a lot of management weaknesses, implementation, wastage of resources, which we are working together to try and close to make sure that the system can improve for the better. Thank you very much.
Thank you. Let's give a round of applause to the Minister. Minister, thank you very much for igniting this discussion. Clearly, it was simply to light a fire of ongoing conversations and try and build bridges. We're going to collate some of the stuff that came out of here in a report that you can also consider, but also Parliament can consider in the process that they have opened. I'm going to ask Mr. Kendani Musibi to come and give a quick vote of thanks. Happy to speak.
Thank you. Hey, the only way to describe the engagement today is that, hey, Ziakala. It's been quite interesting. Minister, I think there's a number of questions that we need to ask as a country, especially when you get Nicholas telling us, Dr. Nicholas telling us that we're spending a lot of money. And my question is, why are we so sick? Because we need to go back to that and say, why are people dying from listeriosis? Why are people dying from cholera? Why are people dying from TB? Right? Because the purpose of healthcare and obviously NHI is to keep us healthy and to prevent us from dying unnecessarily. Right? So there's a question there that why are South Africans so sick that they spend more money than even the most developed countries. And that means that there's something else that needs a solution other than NHI, which would ensure that we actually spend less money when we get into NHI. I'd like to thank the Minister for making the time, having been stuck in a plane, but you still made it such that we can continue with this function. And may we give the Minister a round of applause. In our midst, we have a number of industry players. I think there's a chairpersons of medical schemes, there's a board members, there's a principal officers. But more importantly, Dr. Sipho Kabane is here, who is the CEO of the Council for Medical Schemes. And Dr. Sipho's table there is the one that is very much vociferous about the implementation of NHI. And I think there's a need for the industry to work with Dr. Kabane to make sure that the industry supports NHI. Because at the end of the day, we all want, is it universal health care or health coverage? Health coverage. It's kind of like job opportunities and not jobs. and like, can we, gentlemen, ladies and gentlemen, give Dr. Sipho Kabane a round of applause? The one thing that I know, I'm the chairperson of a medical aid administrator. The idea that medical administrators will actually disappear with NHI is not quite accurate. I think the functions that we provide in the healthcare environment may change. And I think you've seen us in terms of what we present, that we're in biotech, with the CDE, we also have a online pharmacy. There's a whole lot of services that NHI will require that we can play. And I think the name of the game here is adaptability. Right? As the environment changes, the industry must adapt. Oh, Dr. Letlape, I never thought that there's anybody who's as passionate about any subject as I am about the subjects I'm passionate about. Right? And it's a man that I think we can be very good friends, Doc, because we hold very strong views where we have views. I still want to understand from you, in a private session, how does my post-tax contribution become a social fund? And would like to have an engagement with you going forward. And also whether this NHI will result in the men from Alex and the women from Alex getting to have access to Center Medical Clinic, or it will force me to Baragwanath. And those are the questions that we would like to see, because NHI must happen. Right? Some form of intervention must happen. NHI or whatever that you are thinking, something has to happen. The situation cannot exist. I think the reality of the matter, Minister, is that inequality in this country is everywhere. I don't know if we're going to have NHI for education, so that those that are in private, taking their children to private education can get the same effect of NHI type of an intervention in a private education, in housing, in security. Some people who are sitting here have security guards in at their gates, and some are driven by bodyguards. And all of that, to me, is a totality of the inequality in South Africa. Dr. Lenyenye, we're not against the generics. We have this thing that we're innovations-based organizations. There are organizations that are based on generics. We don't want to copy them. We administer a medical fund. We prefer generics where there are generics. So it's not an anti-generics thing, but it's more to say, because someone else is already doing generics, we're not going to do generics. We're going to come up with innovations that actually meet unmet medical needs. So it's a completely different view of life. Is this a frank dialogue on NHI, or the first frank dialogue in NHI? That's a question. And JJ, I think it's very much incredible that the minister has come and allowed ordinary people to ask him questions. But NHI is trying to address this elitism of healthcare. And there's a Gauteng elitism. So perhaps you do need to take the minister to the Western Cape, to KZN and other provinces. And I've already consulted with Dr. O and said, I'm going to make a public commitment to JJ and say that we can go to other provinces with the minister. If you can convince the minister, we will support the minister in in engaging the country on NHI, because we do believe that it's an important program. I'd like to thank the panelists and their contribution to the debates today. If NHI was not an important, if healthcare was not important, we wouldn't be sitting here. And the panelists would not be as passionate about their views on NHI as they are. And I think they've done a good job in coming up with thought-provoking ideas, right? And expressing themselves in a way that actually help us to think about the impact of NHI in our lives. And may we give the panelists a round of applause. And lastly, you have Equivex on your tables. Some of you have drank your bottle, some haven't. I want to challenge you, because this product here, it's manufactured it's the only water, certainly in South Africa, probably in the whole world, that is manufactured in a CGMP facility. In other words, it's manufactured in a pharmaceutical facility. It's at the highest standard of quality that is actually checked by SAPRA, where they have to comply with the CGMP standards. Now, if you've had the wine, a lot of wine tonight, and maybe you're going to go back and drink, I challenge you to make sure you have a full bottle, and send us a comment tomorrow how you feel in the morning. If you have a problem with sleeping, go Google the impact of CBD on insomnia, right? And we've delivered a product that actually has got the full bioavailability. And then the people always ask us if CBD helps with hey. Go find out for yourself. And for those that can't handle Equivex, we've come to the end of the program. You can stop at the next filling station and get Prime or Oros. And the consequence of it, which is diabetes, do take Grand Newton's numbers, because the Center for Diabetes and Endocrinology deals with people that actually like these sweet things. Thank you very much, ladies and gentlemen. And give yourself a round of applause.
Yes, thank you, Dr. So, Mr. Kandani, thank you so much once again to 360. You've heard them. It's not me. They have said we can go to other provinces. We've got 9 provinces, so we still have to do 9 provinces. Okay, 8 to go. But Minister, they're saying on condition you come along. So you are standing between us and their sponsorship. So please do come along. Faith, what did you think?
Sure. I think as we close off the session, for me, and I count as the ordinary South African, right? Maybe perhaps a little bit more privileged because I do have access to medical aid. But every time somebody was speaking, I thought to myself, my goodness, my Koko from Ilguatini, if she only had the same privilege that I do. And how dare I allow the very same status quo to continue, as you were saying, Doctor, and think that I've achieved something. I think we've all achieved something when we can all have good quality healthcare. That's when we're really winning, when it's good quality healthcare. And I must thank you, all of you. There is something amazing about being in a room, and I was saying this sharing this with colleagues here on the table, that I've never felt so safe because I'm in a room with people who care. The reason why you are in attendance and you are staying until 10:35, 10:50 actually, is because you genuinely care about the discourse of this country. And because of your caring, you are still here. So I would like to appreciate you, and I would like to thank you, number one, for showing up, and number two, for caring enough for this country to actually engage in robust debates and conversations that allow us to change South Africa. So for me, it's an acknowledgement and a gratitude to you. I feel safe, and I know that South Africa is much better because you are in it, and you care enough to do something about it. Nyabong.
Thank you very much. I'm told that the bar wants to take the last round before you all go home, and please don't drink and drive, and drive safely. Before we go, Tlalani Map, I'm sure you received an email from somebody called Tlalani Mapati. She's a general manager of Sigwili Media Group, and I would like us to thank her and her team. Tlalani, where are you? Just wave where you are so people can see you. Tlalani and her team have put this together truly in a fantastic fashion. And we really want to say thank you for what you have done. And thank you for your cooperation with them, phoning and confirming and this and that. So thank you so much to everybody. And once again, Mr. Lebo Khadebe, let's give him a round of applause, Chairman of Sigwili. Otherwise, let's adjourn just to resume again the discussion. As we've said, we will take the report, we will share it with you when it's complete, but we'll also, more importantly, make sure the Minister has a copy by next Wednesday or Thursday, and then Parliament has a copy by next Friday when they are closing for public comment. Thank you very much for your participation, and good evening.
Hello? Hello?
Ladies and gentlemen, there's a white bag with some gifts. Please don't leave it under your table. It's meant for others to be wasteful expenditure. Please take it with you.